Everybody, and thank you for coming to the Yale Cancer Center Grand Rounds. We have a very special guest this afternoon, Dr. Paul Taheri, who is the CEO of the Yale Medical Group and the Deputy Dean for Clinical Affairs. Paul has been at Yale for approximately 2.5 years or so.
That's right. And
his tenure has been transformational, I think, for the entire medical practice in all locations. So I heard Paul present on YMG about 2 months ago at the School of Management, and I felt that it would be really helpful for everybody at the Cancer Center to get his perspectives on YMG, where it is now, where it's going, and then get some feedback from the group. So Paul, thank you very much for being here today.
Thanks, Rogerio. So thanks for having me, by the way, and I always appreciate the free beverage. Nothing's free, so you're stuck here for almost an hour. But the good news is I only have about 10 slides, I think maybe 9. So really I actually want to have a bit of a conversation so you don't I actually did it on purpose without a lot of slides. We have no choice, otherwise we're going to get out early. So, just very briefly, I have one slide who I am. I'm actually a general and trauma surgeon by craft. I used to run the Trauma Center at the University of Michigan, and then I went to the University of Vermont. And I've been here, as Rogerio said, about 2.5 years as the head of the medical group. So I thought I'd spend a little bit of time telling you what I do every day. Not that you really care what I do, but you do care as faculty or as fellows, as residents, students, other folks, just to have a sense of what does a medical group do and what keeps you going every day. So a bit of an overview here, just so you know, the medical group's about 1,500 doctors, maybe slightly less than that, but you'll hear lots of different numbers. It just depends how you count. We do about $750 million a year in annual revenue. That's revenue that's done by E&M codes or procedural codes. All the work that you all do and Smile every day adds to that number. This is not hospital-based revenue. This is physician-based revenue. Our group has been growing long before I got here, for about a decade before I got here. It's growing about 9 to 10% annually. That's very big growth in the United States today. So generally, most places are seeing relatively stable to flat growth. This is very big growth. I anticipate this will start hitting its sort of asymptotic edge here and start flattening out and be more logarithmic than exponential. But that's just because over time, we'll talk a little bit about this, but what you see in the nation, what you see in New Haven, what you see in the state of Connecticut is consolidation, whether it's hospital consolidation or practices. We'll talk about that in a second. So a couple other things. We have over 100 practice sites across the medical group. This sounds like a lot. It is. It is actually very hard to manage, just so you have a sense. There's a lot of variation in the medical group. I think this is one thing I want to convey to you all, that across the group, whether you look at cancer, you look at medicine, you look at surgery, you look at pediatrics, etc., huge variation in how this group operates. And the real reason for that is mostly the history of the medical group. Just that it's really evolved from 20 different clinical departments, and now we're trying to bring everybody together as a group, and I'll speak to that a little more. But what you get as a result of that is a lot of variability across the practice. Just so you know, we are YMG, the faculty of YMG are all Yale University employees. We are a separate corporate entity from Yale New Haven Hospital. We're bound by what's called an affiliation agreement. That's very common in academic centers. And basically that agreement is 99 pages long, and it basically says you will get along. It's not specific, it doesn't say how, it just says you're going to do it. Okay, that's not a critique, but that's just kind of how it's set up. So a couple of just, basic goals to just sort of get an understanding of what's going on in our environment, how YMG is kind of organized, how do we work, and then really to have just a conversation, open conversation with you all. So here's what's happening in our marketplace, and really our marketplace is no different than Kansas City, New Orleans, or wherever else, whoever had a football game. Who played a football game last night? Whatever those two cities were, they're the same. Okay, so here's what we're seeing. Here's what you're going to experience, whether you stay here or go somewhere else. Consolidation. Huge issue. Why is everybody trying to get together? A couple of big reasons. One is scale, right? If you can be bigger, you can have, in theory, one CEO, one CFO, not two organizations each having the same administrative overhead. So you can consolidate overhead and you can spread it across a bigger base of provider or a bigger base of revenue. That just creates some efficiencies. That's actually generally true, assuming you actually execute on the consolidation. Okay? If everything stays the same, you haven't done much. So you just need to keep that in mind because there's a tendency to acquire everything and then nothing changes. That's not a good model. The only people who benefit from that are the lawyers. Okay? So docs generally think about it in the same way. They want to get bigger, not so much because they want to all coalesce, but generally they recognize that they need to for a couple of reasons. One, all that back office stuff of IT expense, all the administrative expense, but also they feel there's a lot more strength in numbers, better contracting with the payers. We can all do this together better, quite frankly, because I think it allows for clinical integration. Everybody talks about things like clinical integration and population health. Not that many organizations are really doing it particularly effectively. We're not. We got a lot of work to do. Of course, we talk about it, but that's kind of the academic way, quite frankly. But we have a lot of work to do. Actually, Smilo is probably one of the more integrated places because you're much more focused on the continuum of care. We're starting to get there, I think, in orthopedics with some of the bundles, looking at pre-index admission, for the hip or the knee joint, and post-index admission, looking at, skilled nursing facility and home care and trying to tag those patients so you know if they bounce back in the same bundle episode, et cetera. So there's some very legitimate work going on inside the organization today to do these things. We're just not as far as advanced as I think we'd like to be, and I think that's true in many organizations across the country. Price transparency is another big issue that you hear about a lot from the state legislature. Patients come in and they get these big bills. Last year I paid $50 for an EKG. Now it's $250. What happened? Same doctor, same building, and yet it's more expensive. That's actually true. So there's a lot of issues around price transparency. So I won't bore you with details, but if you really look at the legislation, they want us to disclose our prices to the community and to the patients. That makes a ton of sense. Nobody disagrees with that, but how are we going to do this? You can all imagine how many prices there are just inside one discipline, even of oncology, right? There's a visit with this, with that. All these things add up. So right now, just so you know, YMG will provide patients with a pre-visit price. Like, what's it going to cost me to have my hernia fixed, my gallbladder taken out, whatever it is. We do that. It takes a lot of work. That's our problem, not the patient's. But it is always an estimate, right? Because people can come in and then they need a cardiology consult. They have a little heart failure. They got to spend a night in the unit. They didn't think you needed to, whatever. Well, the price just went up. So there's a lot of issues related to how do we actually do this. So another big issue related to the Accountable Care Act and what we're certainly seeing, if you will, on the ground is the need for physician leadership. As Ruggiero mentioned, we actually have been working with the School of Management to try and train a cohort of physicians in an ongoing way. Really, we've established a curriculum that covers the basic business principles, finance, marketing, operations management, those kinds of things. It's a one-day for each discipline. I think it's a 9 or 10-day course over the course of the year. And then the second year, there's sort of an advanced, much more focused on individual leadership tools and teams and empowerment. But the idea is for YMG and the hospital, we sort of fund this collectively to start getting the physician cohort through a sort of a fundamental curriculum on the basic business principles so that everybody can at least have a similar headset as we go through. So we have 40 docs going through each of these two curriculums. One is sort of the management one, and the second year it's sort of the leadership one. So over the course of a year now, we kind of have a steady state of about 80 physicians taking this curriculum because there's really a dearth of true physician leadership across most hospitals and health systems. So we need more docs, not less. The last thing that's going on in our market and everybody else's is the ability to bear risk. This is sort of a little bit of a confusing issue, because what really is risk? Is it financial risk? Is it clinical risk? Population risk? How is it distributed? Does it get to the doc individually? And we wrestle with these things too. So managing risk is a big deal. We actually, in the medical group, engaged in a capitated relationship with the Yale Health Plan, which is covers, I think, a fair number of people probably in this room. It's about 38,000 covered lives. And the medical group, which is, I think you're aware, is largely a specialty group. We don't have many primary care providers. We have some, but not many. And we went at risk for that capitated relationship. So what that means is a health plan pays the medical group $25 million a year, and for that we provide all of the services, specialty services that are required. This doesn't include the hospital, it doesn't include the pharmacy, it doesn't include durable medical equipment, but it includes the physician cohort of the specialists. So in an ideal setting, you would want to include everybody, because then you could really share in the management and the benefits of potentially reducing utilization. Nonetheless, this is really, we did this for a couple of reasons. One is it's actually relatively low risk. At the end of the day, if you're going to capitate a population, you really want to try and do it with a group of professors and students and people that you sort of have some oversight over, and some, I would say, limited control, but at least you kind of know who they are. Two, it's getting us ready for when the real payment relationships change. Okay, so with this SGR fix, which was the whole fix that had, the Medicare fix that had been in Congress, I think 17 different times, it had gotten an extension. They finally fixed it this year, but when they fixed it, they said, we're going to continue to pay the doctors, I think, a 0.5% increase in the professional fees until around fiscal 18. At that point, you're going to have to go into a value or a MIPS program, and basically there's some notion of it's not about volume, it's about value. And so the reason to do this capitated relationship now is to begin to prepare us as a medical group to understanding the best way to shift from volume sort of to value, if you will, because the federal government's already going to make the change in a couple of years. So we have to be ready to sort of move almost the Titanic, because this, by the way, is the Yale Health Plan is $25 million on a book of business about $750 million. So it's only about 3.5% of our business, but it's sort of the canary in the coal mine, if you will. So the idea is just to begin that understanding. It creates a different administrative structure, different reports, how we are going to manage certain things. So this is a good thing that we're doing, but it's done in light of the future. And the only bullet point I have at the end here is that, you know, whether we like all these changes or not, it doesn't really matter what you like or don't like. It's here, so we have to deal with it. So how do we run the medical group? What's the point of it? What do we do? I think there's some very important principles of YMG that everybody should be at least aware of. One is that my role, and I can tell you the chair's role, is really to represent the faculty. And I'll go over our governance structure in a second, but the idea is, you know, you don't have a group if you don't have faculty. So at the end of the day, it's about the faculty. We have to be transparent. Everybody sees on the board or on the finance committee, everybody sees the numbers. There's no hiding numbers. We're done with that stuff. There's no double secret meetings. There's no like room where there's a special meeting that's soundproof or anything like that. We don't do that. It is what it is. And so we see what everybody's doing. I know that you all pay my salary effectively, as well as the other administrative folks inside the medical group. So that's just a reality of it, because money's got to come from somewhere. We do have a lot of practice standards we're trying to institute. Remember I mentioned that issue of variation? Well, we just have to have some standards in the practice. So we develop these standards. They all go through the various committee structure of the medical group, and then they get approved by the board. So the point of this is we just simply have to have standards. The days of everybody having their own special set of stuff because of who they are is kind of going by the wayside, just because this group is way too big to have 1,500 sort of quarterbacks, if you will. So anyway, we're working on a lot of practice standards. I do think that the issues are moving very fast around us. You know, almost every week or every other week, I'm in a conversation about some group is talking to some group, or some hospital's talking to this hospital. about who to partner with, who to hang out with. So one of the issues is we just have to be able to move much more quickly than in the past. So getting everybody working in a governing body is really important. And then at the end of the day, I'm measured, or other people are measured, about what'd you get done. Nobody cares how many meetings you have. Nobody cares how much you got to see everything, but what'd you get done? So at the end of the day, I want to convey that YMG is really committed to trying getting stuff done. So I'll talk about groupiness at the end, but I wanted to talk about this. This is the governing structure of the medical group, okay? Very simple. Remember, I'm a surgical type, so it's basically, you know, a picture, very easy, like a comic book. I'm in, okay? So we have a board. The board consists of all of our chairs and 4 faculty members, myself, and the dean has reserved powers. He doesn't attend the meetings, which is actually good, because the dialogue is very good amongst the chairs and the faculty who attend. It's pretty open, because if the dean was there, they would tend to play to the audience. So Bob just doesn't come, and I think that's actually a good thing. So we have a couple of committees of the board: a finance committee, an operations committee, a network development committee, and a nominating and governance committee. These 3 meet every couple of weeks. This meets periodically when we need to change sort of the cohort around. But everything is chaired by faculty member or chair. So the medical group board is chaired by Gary Desir. Finance is chaired by Hugh Taylor. Operations is chaired by Gail D'Onofrio. And network development is chaired by Pete Shulam. You guys know Pete, right? Yeah, okay. That was a joke. I mean, let it out a little bit. You know what I mean? So everybody on the board is assigned to one of these committees, and then we add 3 more faculty members to each of these board committees. So the real idea here is that this is the idea behind the governing principles of the medical group. It's really about the medical group. It's not a bunch of senior administrators from the university or the hospital. It's not. It's the medical group's group. There's your chairs and a bunch of faculty. So that's kind of how we run it. All the information kind of flows through these committees. The decisions generally are made here, and then they tend to be ratified or rediscussed at the board. So things around budget goes to finance committee. Practice standards generally go to operations. Where we're going to put a outreach post like Stanford, which we're working on right now for musculoskeletal, that's all that work's being done in network strategy, network development. So there's sort of a cadence to this. There's some organizing principles. This is simply just administrative workflow. So each one of us, myself, were assigned to one of these committees. So I really staff this committee. Gary Desir, who's the chair of it, and the chairs and the faculty members are on the board. I really work for them. So they decide stuff, and then between the meetings, me and this cohort carry out the work, bring it back, and then people vote on it or not or whatever. So that's the idea about how it works. So if anybody want to know what you do in a medical group, this is sort of a laundry list of stuff. We tend to have them organized by committee, so you can see kind of what you're paying for. And so there's actually a lot going on. There's a lot of issues here, and then all the day-to-day fire drill stuff that we all deal with. We deal with it too. So there's just I think the thing I want to just sort of get everybody accustomed to here is there's really a lot of things going on. Some of these things are, like physician productivity. That's not exactly a small topic. It's one bullet point, but there's a lot that goes into that. Measuring the CFTE and all these, what benchmark, all this stuff. So there's a lot going on that is really inherent to a practice, and a lot goes on that gets done that's inherent to an effective practice. So a couple of quick things that I wanted to mention. We're working on time here. But when we talk about money, everybody likes to talk about governance and money. Look, at the end of the day, that's what it boils down to. Who controls money? Who decides what? These are the kind of things that are important. So when we talk about the finances, I think there's a couple of key features here. One, as I mentioned, we think about ourselves as a medical group. So you can always optimize your own silo. So if I was a singular department, I'd make decisions, I would do things that would make my stovepipe better, right? But I might do that at the sacrifice of somebody else's silo over here. So the idea here is to actually break down that silo and have the conversations around what we need to do. You still may end up with the same economic decision making that occurred in your own mind in the beginning, But the key is you had a conversation about it and everybody came to agreement about it. It's not like you're going to sort of win every battle, if you will, but these are decisions, these are discussions that actually happen with the medical group finance committee and then at the board. So a couple, I think, important decisions that have been made is that inside the medical group, we cover deficit departments. So some departments are in deficit for a whole host of reasons. It's generally not because people are hanging out eating donuts and not doing anything. Okay, it can be a payer mix problem. There might be some structural problems that you have to have a certain number of faculty just to provide that level of service, and there aren't enough patients. So we see this in like pediatrics, for example. Okay, I don't know of a pediatric department in the country that can make money on its own because of the scope of services that are needed to be supplied. Sometimes there aren't enough kids. So that's one of the issues, and a lot of the payment structure is basically Medicaid. It's really hard to do it on that. So at the medical group level, we develop the budget for each department. The chairs and the board and the finance committee review all that. And then what we do is we cover anybody who has a deficit. That's all approved by the department chairs. It's all reviewed by the board. So it's I think a pretty reasonable model. But the point is this transparency is really key to getting that work done. In the past, YMG used to make money. I'm not exactly sure why, but we've changed that structure. So everything we take in, so we tax every dollar that comes in. YMG, there's a tax, and everybody's like, well, you know, what am I getting for that money? So we tax that money, but at the end of the year, we tally up all the expenses, which we know because we did the budget the year before, but what the actual expenses are, and then the surplus in YMG is pushed back to all the departments. So really, we're no longer a profit center, but it is actually a cost center. So no money stays in YMG. That's, I think, important for the faculty to recognize. It comes in, we have all the expenditures approved in the budget by the finance committee in advance, and then we just push back whatever is any residual that's left. And as I mentioned, we actually enter into this fixed fee capitated contract with a health plan. One of the key issues here that may be a little bit boring to people, but in this discussion, we developed a fee schedule for how to manage this capitated contract. So when we look at the fee schedule across the medical group, huge variation to what was being charged to Yale Health Plan inside the medical group for various services. So you had cardiology charging this, GI charging this, OB charging this, general surgery charging. Everybody was kind of all left to their own devices because historically they had all negotiated separately with the health plan. So what we did was try and consolidate and begin to reduce the variation in that fee schedule across the medical group. So it started to make a little bit more sense. As you can imagine, there was a lot of pushback on those kinds of things, but that's the purpose of having a sort of an open governing process. Because in the end, I think we made real progress on beginning to reduce that variation. It doesn't sound like much, but it's really not easy to do when those who had high fee schedules saw a cut in their fee schedule. And in the end, I think the vote was 17-2 in the board level to approve that change. So that's a very robust sort of governing process, I will tell you, when actually many of the chairs voted for a pay cut because they felt this is the right thing to do as a group. This is a slide I have that just basically gives, I'll describe it in a second here, but the quick take on this is the administrative expense in the medical group as a function of patient care revenue. So the point of this is the following. One, this is the patient care revenue here. This green is because YMG does the billing for NEMG. Okay, so the Northeast Medical Group, we do their processing of claims. And so that is work that is being done by the infrastructure of YMG. This little blue area is actually the YMG budget. So the department of YMG, it's now in 16 is about $68 million. So it has gone up some, went up a fair bit from 15 to 16. All of this increase was approved by finance and the board. So the basic way we run the group is if we want to do something, we develop the plan, develop the budget, and then people vote for it. If they don't want it, we don't do it. So this is up by $8 million, but that's all approved by the board. So the thing to take home, I believe, here is this shows that while we were producing a lot more on the administrative side of the medical group in terms of revenue, really the cost per unit is going down. So it's sort of a way of describing efficiency inside of a medical group. That's the point of it. And the slide looks good, so I like to show people that. So where are we going? What's the sort of the direction? What kinds of things do we need to deal with? Well, one of them is we really need to begin to, or I should say, continue functioning with the Northeast Medical Group as one medical group. We're not there yet. So I'm taking away all the corporate stuff. Forget all who owns who, who's in charge of what. Let's just start focusing on working together and sort of getting that done as a unit. So we are making strides there. We have a group actually that's led by Pete Shulam called PEC, the Physician Executive Committee. And we have 6 of the board members from YMG and 6 members from the NEMG, and we meet every month. We go over lots of things like, you know, who's going to hire what. We talk about areas, dashboards and operational metrics, standards across both practices. What should the patient experience be like? Those kinds of things. So this is a good dialogue that's ongoing. I do think we need to be bigger because as big as we are, we're probably not big enough to sustain the central missions of education and research. So all those, 100 clinics I mentioned and some of those sites around, the idea, as you, I think, well know, is that we generate revenue there. We bring the more complex patients in here to really help support both the teaching and the research mission. So that's, I think, a really important thing, and we are going to need to get bigger, not smaller. Everybody has these things in every slide I've ever seen, so I won't read them to you. But you get the idea. The last thing I was going to say is we are working on new service lines. Ruggiero has been instrumental and really has led a lot of the changes or some of the future of the genetics, not only on the Smilo side, but we're looking at this as a service line in pediatrics and OB as well, and probably in other areas like cardiology. But this is sort of a emerging, what I'll call a service line, just like heart and vascular, musculoskeletal, just like Smilo. I think over time you'll see genetics probably taking on its own platform. Immunotherapy and metabolic health are 2 other areas that we're looking at in various detail. There's right now, if you look at metabolic health at the medical group, there's about 4 or 5 different groups working on it. The surgery has folks, medicine has a couple, psychiatry has one. So we're trying to get this organized and consolidated in a way that it looks like that Yale has an approach to metabolic health, and then it could be distributed based on the specialty of the service inside a different department. But we're trying to basically create a front door here where people would be able to do that. So anyway, that's a couple of quick items here. I just like this slide because I made it. And it's basically all little pieces that go on, and then get ready. There. You see? The key thing is this groupiness stuff. The only way to make this work going forward is if you stick together as a group. And I will tell you that for those of you who may be, graduating in a year or 2, you really want to not only look at your job, but look at the group you're dealing with. You can look at the finances or whatever, that's up to you, but in terms of the culture, in terms of the cohesiveness, in terms of their willingness to kind of hang in there, that's going to be really critical because, as you know from what you do in Smilo, a lot of what you do is a team sport, if not all of it. So this notion of these groups and teams are really evolving in other areas in healthcare, and this is really the key theme going forward. So that's it. So I have 30 minutes. So what do you want to talk about? So